Judge Lavoy, ladies and gentlemen of the Assembly, thank you for inviting me to talk here this morning. I work as a neonatologist, and that's a qualified paediatrician who specialises in the care of critically ill newborn babies from preterm to term and beyond. As Peter alluded to, there are many babies born in Ireland with congenital anomalies, from the minor to the major, and thankfully the majority of these babies survive and go on to have good lives. Some are complex, and with anatomy scanning and the more advanced testing Peter took you through, most are diagnosed before the baby is born. Parents are prepared and have good counselling. Often, though, not always this is possible, and in some cases it comes as a big surprise both to the parents and the doctors and nurses looking after them. For those babies that don't survive, the advances in paediatric palliative care, even in the last 2 or 3 years, we've nurses now in our neonatal intensive care unit specialising in paediatric palliative care. We manage these babies and these families in a much more sensitive and appropriate way than we did in the past. Just to give you some ideas of numbers, in the paper there's appendices with a lot more data, and I think the clinical report from the Rotunda is going to be on the website if you want to get more of a sense of numbers. But there were about 9,000 babies born in the Rotunda Hospital last year, and about 1,300 of these required admission to our neonatal unit. Not all of these from the Rotunda, a lot of these were babies from outside Dublin. But 240, or just under 20% of these babies that required admission had congenital abnormalities. If it's a minor thing like a preauricular skin tag or a cleft palate, we'll often try and keep these babies on the ward with the mum. So the ones that require admission are the babies with more complex abnormalities. To give you a sense of national figures, in 2015, over 300 babies with congenital abnormalities were transported by the National Neonatal Transport Programme. So this is a service run by the Rotunda, Holles Street and the Coombe. We alternate a 1 in 3 rota. We cover the whole country 24/7, including Christmas Eve, Christmas Day, and we retrieve critically ill babies. So the number of 322 might seem small when we had 240 babies admitted to the Rotunda in the same year with congenital abnormalities, but these are babies that require intensive care and transport and urgent admission either to one of the maternity hospitals in Dublin for intensive care or to the Children's Hospital for surgery. And you'll get a sense of how the numbers have increased over the years. The red line represents the Dublin hospitals. So while we can give intensive care in the maternity hospitals in Dublin, the babies that maybe require transfer for surgery are transported by the transport team. The green bar represents babies born outside Dublin, and you can see that's significantly higher, and then the blue is the total. The significant increase in 2012 doesn't represent an increase in numbers of babies born. It just represents the service going from a 9 to 5, 7-day-a-week service to a 24/7 service. So occasionally 2 babies are born at the same time, maybe one in Letterkenny and one in Sligo, and we as the consultant at base have to make a call which baby to go for. But I can say that most babies are transported by the neonatal transport team in a safe and timely fashion, and this has improved the outcome and care these babies receive. So I'm going to take you through 4 clinical cases. They're not fictional in the sense that these are real-life cases I or one of my colleagues have been involved in, but obviously for the purposes of confidentiality and Ireland being such a small country, details have been changed so no baby or family can be identified. So the first is a lady who's 37 years in her first pregnancy, and at the anomaly scan there's a suspicion that this baby may have Edwards syndrome, and Peter has already taken you through the prognosis and the life expectancy for these babies. An invasive amniocentesis, the procedure Peter outlined to you, is done, and this confirms the baby does have trisomy 18 or Edwards syndrome. The outcome and survival data are shared with the parents. They have counselling with the neonatologist, the fetal medicine specialist. They decide to continue with the pregnancy, and a clear care plan is put in place. David is born at 37 weeks, weighing 4 pounds 6 ounces. Because the care plan has been put in place, the parents go to the gynecological ward in a single room, so there's no other newborn healthy babies around them. They get to bath David, the grandparents get to visit, they get to dress him, they take little imprints of his hand and feet, and he passes away 12 hours later and they take him home. They are offered bereavement follow-up, but because they felt everything was planned in advance, they don't avail of this. The second lady is a little bit more complex. She's a 28-year-old lady expecting twins, and at the anatomy or anomaly scan it becomes apparent that the second twin, the little boy, has a very complex congenital heart defect that will require surgery very soon after delivery. However, sadly for her, she goes into labour prematurely at 27 weeks. And labour, as you know, is 40 weeks, so this is 13 weeks or over 3 months prematurely. The minimum weight a baby can undergo this complex cardiac surgery is 5 pounds 8 ounces, and no baby at 27 weeks would be born at that weight. The twins are born 2 days later. Mary, the unaffected twin, is 2 pounds 6 ounces, and John, the twin with the cardiac defect, is 1 pound 13 ounces. We decide to give him every chance, so he's put on medication that keeps the in utero circulation going, and we would do this with full-term babies until we transfer them to the cardiac centre for surgery. And we put him on maximum nutrition to try and get him to grow. Sadly, towards the end of the 3rd week, the duct, the in utero circulation starts to close. He's heavier than when he was born, but he's still not at any weight where surgery is technically possible. Again, there's much counselling with the cardiologist, the parents, the neonatologists and the neonatal nurses. As Peter alluded to, this is not ever a single decision. It's a joint decision with the family and the professionals looking after the baby. Because of their faith, he's baptised, extended family visit. They get to dress him in clothes they've bought. They get to take photos without the medical equipment. And he passes away some 40 minutes after intensive care has been redirected. This family take him home to bury, but remember they still have Mary. So they have to come to the unit for a further 5 weeks, visit Mary, feed Mary. Mum has to express breast milk for Mary. And they come back to the Rotunda over the next 18 months for developmental follow-up for Mary because she's born premature and could potentially have other complications. They do avail of bereavement follow-up. And what they cited to us was that it was the consistency and continuity of care and advice they were given, the fact that David was given a chance, albeit a long shot, and that they seemed to cope quite well, but obviously the difficulty of having the other twin to take care of. The 3rd case is a lady who's born outside a centre where anatomy scanning is routinely available. It's her 4th pregnancy, so things are seen to be quite straightforward. However, her baby has difficulty at breathing at birth and is noted after delivery to have multiple congenital anomalies. So the neonatal transport team go down, retrieve her. She's really, really quite sick the first day she's born. She's on high-frequency ventilation, lots of medications for her heart. She's a really critically ill little baby. After a day or two in the Rotunda, we do a cranial ultrasound scan which shows some brain abnormalities. She's quite difficult to ventilate, and so we're suspicious there may be an underlying disorder, and she's transferred to one of the children's hospitals for more specialist input. 2 weeks later, the genetic result comes back to confirm that Mary has Pato syndrome. And most babies with Pato syndrome are quite low birth weight. They wouldn't be this good weight of 7 pounds 11 ounces. And she doesn't have the typical facies. With this diagnosis and the fact that she's still in intensive care and critically ill, again, with a whole team of specialists involved, care is redirected and she dies peacefully in her father's arms some 20 minutes later. On follow-up with this family, their frustration was the fact that they weren't offered an anatomy scan routinely, and they felt that if that had been done and they would have gone through with more invasive diagnostic testing, and Mary may not have had to endure 2 weeks of intensive care. Although they did value the time they had with their daughter, obviously a baby in intensive care is different from a baby you take home without all the equipment and medication. The last case is a lady who had a very detailed scanning, prenatal testing, invasive testing. And this lady, as happens a lot nowadays, had gone through numerous rounds of in vitro fertilisation. The non-invasive prenatal testing that Peter described was normal, so there was no evidence of a trisomy. Because at the 20-week scan there was a suspicion the baby's skull wasn't properly formed, she had an invasive test to look at more detailed testing. So a microarray test looks at every individual gene. So the way I describe these 2 tests to parents, a chromosome test counts the number of skyscrapers you have, and we all should have 46 skyscrapers, or 23 pairs. So in Down syndrome you have 47 skyscrapers, you have an extra chromosome 21. The microarray is like you're looking at the individual window in every little skyscraper and getting the individual DNA, so you're actually looking at the individual genes. This gives you a lot more information than a chromosome test, but for this baby, this detailed genetic test also came back normal. John was born at 38 weeks by planned section, and he could not be intubated. So this is a procedure we do when a baby can't breathe, and we would, 1,300 babies a year, we do it regularly on a daily basis. We put in an alternative airway and transferred him to one of the children's hospitals for an emergency tracheostomy. So this is where they cut below the obstruction to allow the baby to breathe. He stayed in the Children's Hospital for over 12 months. He went through multiple operations for his skull, for the deformities of his airway. It transpired over the year that his MRI brain scan was significantly abnormal. He really didn't develop well. He was stuck at about the developmental age of maybe a 2 to 3 month old baby. He had seizures that were very difficult to control. And it became obvious, no matter how many times we tried it, he couldn't manage without airway support. So a lot of babies with tracheostomies will go home, and the parents will manage them at home, and there's no difficulty there with training. But he couldn't manage without airway support on top of this. So again, multiple multidisciplinary team meetings with the parents, and with the help of the Jack and Jill Foundation, the palliative care nurses in the Children's Hospital, and the family's own local hospice, he was taken home and spent 3 weeks at home before care was redirected, and then he passed away peacefully. This family found it very difficult, as did we, the medical team looking after them, that we didn't have a definitive genetic diagnosis, although it was clear that John had lots of problems. His DNA has been sent to a laboratory in England that looks at even more detailed genetic testing, and that can take a year or 18 months for that result to come back. So I hope through these 4 cases I've shown you that, like lots of things in life, nothing is clear-cut. In some cases, such as anencephaly that Peter described, it's a little bit easier to counsel parents with a clear prognosis. The anatomy scanning and the prenatal testing, be it the maternal blood or more invasive testing, does help us plan where these babies are born. So even for a baby who may not have a fatal anomaly, if we pick up a complex heart defect, we'll make sure that baby is born in a Dublin hospital so they can get to one of the children's hospitals promptly rather than having a long journey. But it's not always conclusive, and I think the 4th case with all the detailed testing proves that sometimes you just don't know until the baby's born. What I've noticed, even in the 9 years since I've been back in Dublin, that the advances in palliative care and bereavement counselling have really improved how we manage those babies that don't survive and how we help the parents through that. Thank you.